Thank you very much. Thank you, Sky Bangladesh, for giving me the opportunity to present my case here. So my uh, title of the topic is the calcium. This the all the minerals are a powerful enemy. So this is my case. A 57 years old male. He is a police officer. He is diabetic and hypertensive, and he presented to us with the chronic coronary syndrome. He has the classical class 3 angina. Treadmill test was positive, and ECG was not nothing significant. So we advised him to go for the coronary angiogram. And this is the view of his coronary angiogram. In the left system, we can see there is a good flow in the LCX, but in the LED, there is a proximal calcification along the proximal to mid portion of the LED. And RCA is a minor plaque distally, and it is a non-dominant vessel. So if we see the proximal part of the LED, there is a calcium along the whole proximal to midline, and it's like a tram-like linear calcification. We can see the calcium calcification here. And so we decided to go for the PCI. Initially, we down the BMW wire, and then we put a 2 into 10 millimeter balloon. But the balloon was not crossing the distal portion of the lesion. So we, after pre-dilatation, it happened there is a proximal dissection. So later on, we downgrade the balloon size. We went to 1.5 millimeter, 1.5 into 12 millimeter balloon, and it crossed the distal portion of the lesion. And during inflation, it was burst. So we can see in the middle picture, it was burst. So the calcium spicule, it burst the balloon. So we had nothing to do at that time. I was doing that case on a peripheral center. I mean, on a center, we don't have IVUS and rota. So at the time, we again I took another NC balloon, 2.5 into 15 millimeter, but still it was not crossing the distal portion of the lesion. So after the period dilatation, that was the result. So I decided to quit the case here, and as the pressure and hemodynamic was stable, and then there's no ECG change, so I stopped the case here and decided to go for planned PCI. So what is the calcium? We know this is the enemy for all intervention cardiologists. And you know, if there is a coronary calcium, it in terms of death, MI and TLR MACE will be higher, and there is a calcium that can prevent the stent expansion. And the calcium always cause a tremendous disturbance during the PCI. It causes the diffusion like a dog bone effect. So like a dog bone effect, and it can cause the dissection that happened in my case. And during peri procedure, it also caused the inadequate stent expansion and malacquisition. And during the post PCI, there is a chance of stent restenosis if we cannot treat the calcium properly. So what to do? If after wearing the vessel, if we can pass the device, then we have to go for the IVUS first. IVUS will give the information about the calcium scoring. If according to the 0 to 4 score, we can do the further procedure, like we can use the scoring balloon, cutting balloon, we can use the OPN balloon, we can use the atherectomy or IVL. But if no device can cross, then we can directly go to the atherectomy. So here we need to do first the IVUS. So IVUS will give us the information. So next, we plan the PCI in my institute, the National Institute of Cardiovascular Disease, where I can provide the IVUS to the patient. So after wearing down the LED, we again took 2 into 12 millimeter balloon in the middle picture, but still the balloon didn't cross the distal portion of the lesion, and the catheter was disengaged. So we downgrade the balloon in 1.5 into 12 millimeter, and it was past the lesion, and we pre-dilated the lesion. Then after pre-dilatation, and again we took the two balloon and pre-dilated the lesion, but the condition was not satisfactory, so we decided to go the IVUS run. And during IVUS run, we can see in the right portion of the picture, the IVUS camera cannot pass down the lesion. I mean, it is also restricted to the distal portion of the lesion. So where it was the maximum part of the IVUS catheter, we run the IVUS. So that is the, we can see there is a circumferential calcium along the whole length of the LED. and we can see some sort of dissection. And if we see the diameter of the LED, we see that distally it is nearly 2 millimeter, and proximally it is like 2.5 millimeter. So we again took a balloon. In that time, we used the cutting balloon. And after passing the lesion, we can see in the first picture the cutting balloon pre-dilation. It was dog bone effect was disappear. And second time we used again the NC balloon, but it burst in the middle picture. And then we did the pre-dilation completed, and again we did the IVUS run. But still, at that time, we still cannot cross the IVUS catheter down the distal portion of the lesion. And still a little bit we advanced before the previous one, but we didn't cross the distal lesion. So we run the IVUS. We can see there is a dissection also, and all through the LED there is a circumferential calcium. And we can see the diameter of the vessel. It is good. It is more than 2.5 millimeter. So at that time we had cancelled about our rota. So we terminated the process here. At that time, we don't have the IVL. So it was our plan to go for the rotatripsine later on. So this is my case. So calcium is the growing problem that negatively impact the PCI if left untreated. The careful preparation of the vessel for calcium plaque motivation is very important. And you have to have some diagnostic tool in your hand like IVUS. And also for PCI, you need cutting balloon, OPN balloon, and rota and IVL in your lab to fight with calcium. Thank you very much.